This is part 3 of a 3-part series entitled Anesthesia Pharmacology Keyword Review. My name is Randall Schell. As an overview, we will continue our discussion from part 2 on inhaled anesthetics. We'll talk about pharmacokinetic principles, some basic keywords related to that, and miscellaneous pharmacology topics. But let's go back first and start where we left off, talking about MAC. We said that MAC is highest at about 6 months of age, that there are some things that can increase MAC, specifically things that increase central neurotransmitters, such as acute amphetamine use and MAOI use. Hyperthermia can increase MAC, chronic alcohol use, and hypernatremia. Some things that decrease MAC as we age, MAC decreases. With cold temperatures, MAC decreases. Pregnancy, probably related to progesterones and endorphins, MAC decreases. If someone is acutely intoxicated, they already have put themselves halfway to sleep, and MAC is decreased. Other anesthetics like lidocaine, propofol, midazolam that we combine with our inhaled anesthetics reduce MAC. MAC correlates with solubility in olive oil specifically, not blood gas solubility. Blood gas solubility correlates with uptake, while potency of inhaled volatile anesthetics correlates with solubility in olive oil. As previously mentioned, MAC decreases with age, approximately 6 to 10% per decade after 40 years of age. Neonates and premature infants have a lower MAC than older infants and children. So think of the neonates and premature having a lower MAC, then it rising up to 6 months where it peaks and then starts to drop off as we age. MAC of sevoflurane is a little bit unique in that neonates and infants actually have a higher MAC, approximately 3.2%, and older infants in the 6 to 12 month range and children 1 to 2 years of age have a MAC a little bit lower at 2.5%. We can think of MAC as a percentage, but we really should think of it as a partial pressure. So if we think of it as a partial pressure, desflurane being the example here, 6%, 6% of what? 6% of 760 millimeters of mercury, which is 1 atmosphere or sea level. We could say desflurane at sea level, the MAC is not just 6%, but is actually 46 millimeters of mercury. And it is this partial pressure and not the percentage that's the driving force to get the anesthetic to cross lipid membranes in the brain and have its effect. MAC bar refers to the concentration of inhaled anesthetic required to block adrenergic response in 50% of patients. And this is higher than MAC, MAC being 1, ED95 or preventing movement 95% of patients is 1.3 times MAC, and it takes all the way up to 1.5 times MAC to block the adrenergic response to stimulation, incision, etc. Meyer-Overton principle refers to the lipid solubility and potency correlation. That is, the more lipid soluble an anesthetic agent, the more potent it tends to be. Let's look at two different concepts, the first one being vaporizer filling airs and the second one being anesthetic delivery at altitude. Why these topics? Because it requires you to know things like vapor pressure, MAC, and correlating these with the way that our vaporizers work. So let's start with a vaporizer filling air first. You need to know vapor pressure of inhaled anesthetics. Vapor pressure is proportional to temperature. As temperature goes up, vapor pressure goes up. As temperature goes down, vapor pressure goes down. There's less kinetic energy at cold temperatures for these molecules to bounce around and create a pressure. But vapor pressure is independent of atmospheric pressure, which means that, for example, desflurane's vapor pressure is very high at 670. It's 670 whether you're at sea level or up at Denver at altitude. The vapor pressure of isoflurane is 240, and interestingly, it's about the same as halothane, a mostly historical volatile anesthetic now. And sevoflurane has the lowest vapor pressure at 160 millimeters of mercury. And these are all at 20 degrees centigrade. The MAC of our agents range from halothane, again, historical volatile anesthetic, very potent, 0.75, 0.76% or so. Isoflurane, 1.2%. Sevoflurane, approximately 2%. And DES, approximately 6%. So if you know vapor pressure and MAC, you can figure out what would happen if you put the wrong liquid volatile anesthetic in an inappropriate vaporizer. For example, if you put isoflurane in a halothane vaporizer, you know that isoflurane and halothane both have the same vapor pressure of approximately 240. If you set the dial at 1.5%, because their vapor pressure is equal, it's going to deliver 1.5%, but instead iso is going to be delivered instead of halothane. So instead of 2 MAC of halothane, you're actually delivering less than 2 MAC of isoflurane. If you put iso in a sevoflurane vaporizer and set the dial at 4%, thinking you were delivering 4% sevoflurane or approximately 2 MAC, you realize that the vapor pressure of isoflurane is 240, while sevoflurane's is less at 160. Therefore, more than 4% is delivered of isoflurane. Isoflurane has a higher vapor pressure, and so this would be greater than 3 MAC of iso instead of about 2 MAC of sevoflurane. If you were able to put desflurane in an isoflurane vaporizer, the very, very high vapor pressure of desflurane would result in rapid, very high vaporization and overdose. The high vapor pressure of desflurane is the reason why we need the special desflurane vaporizers. For example, when we put desflurane in the special vaporizers, it's kept at 39 degrees, and at 39 degrees it's approximately 2 atmospheres, and we can have a constant delivery then. What about anesthetic delivery at altitude? This requires you to know MAC as a partial pressure and what happens to vaporizers with changes in atmospheric pressure. An example first is the desflurane or Tech 6 vaporizer that's calibrated at sea level, and if you set it at 1 MAC or approximately 6% desflurane, it will deliver 6% at whatever altitude you're at. Remember, that desflurane vaporizer has its own atmosphere of 39 degrees and 2 atmospheres of pressure. So desflurane 6% at 760 millimeters of mercury, or 1 atmosphere, is equal to 46 millimeters of mercury. So we could express 1 MAC as a partial pressure, or desflurane 1 MAC equal to 46 millimeters of mercury. So if we took the desflurane vaporizer up to about 7,000 feet elevation, where the atmospheric pressure is only 600 millimeters of mercury, 6% of that is only 36 millimeters of mercury, which is less than 46, which it was at 1 atmosphere. Therefore, we would have to increase the dial percent to deliver the same partial pressure. Isoflurane is a variable bypass vaporizer, and if it's calibrated at sea level and set at approximately 1 MAC or 1.2% isoflurane, its output will actually change depending upon the ambient pressure. For example, isoflurane's MAC of 1.2% times 1 atmosphere, 760 millimeters of mercury, equals 9 millimeters of mercury, 1.2% of 760. So we could say 1 MAC of isoflurane is 9 millimeters of mercury. If we set the isoflurane vaporizer at 1.2% while at altitude, for example, up at 7,000 feet, where the atmospheric pressure is only 600 millimeters of mercury, it actually will increase the percentage delivered more than 1.2%. I like to think of it as the pressure above the liquid is lower, 600 millimeters of mercury instead of 760, and the little molecules in the liquid can jump up into the vapor phase, and you actually deliver more percentage. But it's a percentage of a lower total partial pressure, and it delivers the same partial pressure actually to the patient, about 9 millimeters of mercury. So you can think of the isoflurane vaporizer as being an auto partial pressure deliverer, but it changes its percentage delivery with altitude, either going up in altitude, or you could even make a case for going down in a submarine where the atmospheric pressure is higher, and no percent dial change is needed to deliver the same partial pressure. Uptake and distribution is the next topic. If you look up at the top right, there is an FA over FI curve, which is alveolar concentration over inspired concentration. And when alveolus is equal to what you have on your dial and inspiring, the ratio would then be 1. And you can see that the agents with the lowest blood gas solubility have the fastest FA over FI, or rise or uptake in distribution. Things that increase the FA over FI include low blood gas solubility. So we can choose an agent like desflurane and sevoflurane and realize that it will have a faster onset. If we increase alveolar ventilation, turn up our minute ventilation, we can increase FA over FI. And this will occur more with the soluble agents, have a greater effect on isoflurane than it will on the insoluble agents like desflurane. A low cardiac output, like a shock patient who's hypovolemic, instead of 5 or 6 liters cardiac output, maybe 2.5 liters of cardiac output. Lower cardiac output results in a faster FA over FI. And second gas effect, which refers to, for example, administering nitrous oxide 50% along with a volatile anesthetic. You can speed the onset of the anesthetic state, increase the FA over FI. And if you look up at nitrous oxide and desflurane in the FA over FI graph in the top right, you may have asked, well, wait a second, desflurane has a lower blood gas solubility than nitrous oxide. Why does nitrous oxide have a faster FA over FI? And the answer is concentration effect. We are delivering high concentrations of nitrous oxide, and because we're delivering high concentrations, the concentration effect takes over here, and you have a greater rise in FA over FI of nitrous than desflurane. Things that decrease the FA over FI: high blood gas solubility, halothane and iso, slower onset of the anesthetic state. If you have a very high cardiac output, the soluble agents will be affected more than the insoluble agents. The soluble agents being isoflurane, the insoluble agents being sevoflurane and desflurane. So the very anxious patient with a very high cardiac output could have a decreased FA over FI. Then the patient with a severe right to left intracardiac shunt or interpulmonary shunt can have a decreased FA over FI. And right to left intracardiac shunts are the cyanotic shunts like tetralogy of Fallot, transposition. And so much blood is bypassing the lung in this shunt that it decreases the FA over FI. An example of an intrapulmonary shunt is a main stem intubation. For example, when your tube goes down the right side, you're ventilating only the right lung, but blood is going also to the left lung. And this dilutional effect of shunted blood containing no anesthetic on the partial pressure of anesthetic in blood coming from the ventilated lung occurs more with the insoluble agents, DES, than the soluble agents. And notice that this shunting or VQ effect affects the insoluble agents more than the soluble agents, while ventilation and cardiac output effects affect the soluble agents more. Second gas versus concentration effect. Concentration effect is shown in red in the graphic on the far right. The greater the inspired concentration, the greater the rate of rise of FA over FI. And the example on the far right is administering 10% nitrous oxide versus 70%. And there's a little bit faster FA over FI for the higher concentration. And this is the same for inhaled agents. If you crank up the concentration, there's a faster rate of FA over FI. The second gas effect is a special case of the concentration effect, and it is demonstrated in black in the graphic on the right. If you add nitrous oxide plus a volatile anesthetic together, there's a faster uptake. Nitrous oxide has an extremely high partial pressure. We're giving a large amount of it, i.e. like 50%. And it leaves the alveoli rapidly, concentrating the potent agent that's left and increases the FA. And so second gas effect speeds the onset of the anesthetic state. There are some special situations where actually uptake is more rapid. In infants in pregnancy are those two examples here. First, in infants, volatile anesthetic, i.e. sevoflurane, has an uptake more rapid than adults. Well, why? One, there tends to be a higher alveolar ventilation in kids. There's a little bit smaller FRC. There's a greater proportion of the cardiac output that goes to the vessel-rich group of the brain. And kids have a higher water content, and inhaled anesthetics are less soluble then in infants than they are in adults. And you know that lower blood gas solubility results in a faster uptake. So there's multiple reasons why an infant has a faster uptake of inhaled anesthetics than do adults. During pregnancy, volatile anesthetic uptake is also more rapid. Several reasons for that: increased minute ventilation, they're breathing spontaneously, and a decreased functional residual capacity speeds the onset uptake. Volatile anesthetics are broken down, and that's called biotransformation. And there are some metabolites of our volatile anesthetics that can cause problems. First of all, if we line up our volatile anesthetics from most metabolized to least metabolized, historically halothane was the most metabolized at approximately 20%, Sevo approximately 2 to 5%, iso approximately 0.2%, and desflurane approximately 0.02%. Nitrous oxide is very little metabolized, and xenon is not metabolized at all, a future potential anesthetic. So you can see that of our commonly used inhaled volatile anesthetics, sevoflurane is the most metabolized. And if you use the rule of twos to remember this, halothane's approximately 20%, Sevo 2%, iso 0.2%, des 0.02%. You can line them up from left to right. Desflurane, in the presence of a dry CO2 absorber, can produce carbon monoxide. Now, isoflurane can also do this, but desflurane is the bad actor in this situation. Now, realize that desflurane is not producing carbon monoxide in the body. It is producing carbon monoxide in the absorber, and this carbon monoxide then can come back into the body, bind to hemoglobin, and form carboxyhemoglobin, which can be detected with a co-oximeter on your arterial blood gas, but not on your SpO2 monitor. Sevoflurane, in the presence of a dry or moist CO2 absorber, can form compound A, but compound A kills rat kidneys, but doesn't appear to have a large effect, clinical effect, on human kidneys. But to keep compound A levels low, there's FDA recommendations of keeping your total fresh gas flows 2 liters or greater. Immune-mediated hepatic injury, or quotes halothane hepatitis, is most commonly associated with halothane, also can be rarely associated with enflurane, isoflurane, and desflurane, and probably not sevoflurane. So of our modern inhaled anesthetics, yes, isoflurane and desflurane case reports of immune-mediated hepatic injury, but it's extremely rare compared to the way it was when halothane was used. Free fluoride ion, since these molecules are volatile inhaled anesthetics, have carbon fluoride bonds, fluoride can be broken off, and free fluoride can potentially cause problems in the kidney. We knew that with methoxyflurane that fluoride could block ADH at the kidney and cause a high output renal failure. Sevoflurane results in the highest free fluoride ion concentrations of our commonly used volatile anesthetics, but there's no evidence that it causes high output renal failure. The National Institute of Occupational Safety and Health in the United States makes recommendations for trace gas concentrations. And that is, if you're using isoflurane, sevoflurane or desflurane alone, 2 parts per million is that high-end recommendation. Don't exceed that. Nitrous alone, 25 parts per million. And when nitrous and the halogenated agent are combined together, the high level of the halogenated agent is only supposed to be up to 0.5 parts per million. A take-home point, if you can smell your inhaled volatile anesthetic like sevoflurane or desflurane in the operating room, you are way, way, way above these NIOSH recommendations. Here's a question for you. Which one of the following inhaled anesthetics is appropriately matched with an associated complication? Sevoflurane and immune-mediated hepatic injury? Well, no. It's halothane that's associated with that. Isoflurane and CO2 absorber fires? We didn't talk about that, but sevoflurane causes some of the highest temperatures in the CO2 absorber and has been associated with CO2 absorber fires. Desflurane and carbon monoxide poisoning? Yes, desflurane can be broken down to carbon monoxide and cause carbon monoxide poisoning. And sevoflurane and fluoride-induced nephropathy. Yes, sevoflurane can result in free fluoride ion, but doesn't seem to induce nephropathy. Let's talk about the volatile anesthetics now and some of their physiologic effects, starting with the cardiovascular system. The inhaled anesthetics decrease mean arterial pressure as we increase their concentration. You turn up the dial, the concentration goes up, blood pressure goes down usually. Why? Because Sevo, Des, and Iso decrease the peripheral vascular resistance. There tends to be a reflex increase in heart rate and a maintenance of cardiac output. Inhaled anesthetics can prolong the QT interval on the electrocardiogram, and patients with congenital long QT syndrome, we would worry then. Is this a problem? Well, patients with prolonged QT syndrome have been anesthetized safely with all of the modern inhaled anesthetics. These patients are usually on beta blockers, and when they're on beta blockers, it seems to be safe to use volatile inhaled anesthetics, although some might use a TIVA-based anesthetic. Desflurane is unique in that if you rapidly increase the concentration or turn up the concentration to a high amount at the very beginning of an anesthetic, you can see sympathetic nervous system activation and an increase in norepinephrine levels. This tends to be transient for minutes, 4 to 6 minutes, and is probably related to stimulation of medullary receptors via tracheal irritant receptors. So the desflurane in high concentration irritates the receptors in the airway, sends signals to the medulla. Medulla causes an increase in norepinephrine stimulation because it senses stress, and this norepinephrine results in the sympathetic nervous system activation. Interestingly, this also occurs if desflurane is administered via cardiopulmonary bypass circuit, bypassing the trachea, so it's not all tracheal receptor irritant. Desflurane, however, is not contraindicated in patients with coronary artery disease. What about the central nervous system? Inhaled anesthetics put the brain to sleep and decrease oxygen use by the brain, so CMRO2 decreases. But they also are cerebral vasodilators, and as they vasodilate the cerebral vasculature, cerebral blood flow increases. So blood flow is going up as cerebral metabolism requirements go down. If cerebral blood flow goes up, cerebral blood volume can increase, and there possibly can increase intracranial pressure. But if you hyperventilate the patient, this blunts this increase. High concentrations of volatile anesthetics can decrease the electroencephalogram activity in a dose-dependent manner, and BIS monitoring takes advantage of this. As you go up on your inhaled anesthetic, your BIS number goes down. In fact, if you deliver very high concentrations of desflurane, isoflurane, or sevoflurane, you can flatten the EEG. Sevoflurane is somewhat unique in that it is associated with emergence delirium in kids, and this does not seem to be decreased even when oral midazolam is given to them preoperatively. Pain may be a confounding factor, but sevoflurane, emergence delirium in kids, put that association together in your head. When you're monitoring somatosensory evoked potentials or motor evoked potentials, volatile anesthetics can affect those. SSEPs first. Although volatile anesthetics can be used during SSEP monitoring, they will decrease the amplitude and take longer for the signal to get through, that is, increase the latency. But if you keep your MAC at approximately 0.5 to 1 MAC, SSEPs can be monitored while delivering a volatile anesthetic. However, most people will choose a TIVA-based anesthetic with SSEP, but especially with motor evoked potential monitoring, because volatile anesthetic greatly decrease motor evoked potentials, and a TIVA-based anesthetic is indicated in that situation. What about the respiratory effects of volatile anesthetics? Volatile anesthetics cause a patient to pant who is not paralyzed and is breathing spontaneously. That is, their respiratory rate goes up and their tidal volume goes down. So there is alveolar hypoventilation, and with alveolar hypoventilation results in arterial hypercarbia. The CO2 goes up. And the apneic threshold goes up with spontaneous ventilation. So if you put an LMA down someone after propofol induction, turn on sevoflurane, you will often see end tidal CO2s of 50, 55, maybe even 60 sometimes or higher. And if you try to breathe them down lower, taking the bag and ventilating that patient down to, let's say, an end tidal CO2 of 40, they are unlikely to breathe spontaneously until their CO2 rises back up because of the increased apneic threshold. Now, because the patient pants under volatile anesthetic, where the respiratory rate is high and the tidal volume is low, there is an actual increase in dead space ventilation. Normally, dead space over tidal volume, VD over VT, is approximately 0.3. That is, if your anatomic dead space is approximately 150 mils down to your terminal bronchioles, and your tidal volume is normally 450, the ratio of 150 over 450 is approximately 1/3 or 0.3. So ratio of VD over VT is 0.3. But if you're breathing a volatile anesthetic and your anatomic dead space does not change, it's still 150 mils, and your tidal volume drops to 300 mils, the ratio then of VD over VT is 0.5, and more is going to dead space, and you have less alveolar ventilation. Ventilatory response to hypoxia is profoundly blocked by volatile anesthetics. So if a patient becomes hypoxic who's breathing spontaneously under a volatile anesthetic, they will not hyperventilate the same as they would in someone who was not breathing a volatile anesthetic. And even very low subanesthetic concentrations like 0.1 MAC profoundly inhibit this hypoxic response. The ventilatory response to CO2 is also inhibited by volatile anesthetics, though not as much as the hypoxic response. But at 1 to 1.5 MAC, essentially the CO2 response is absent. That is, as the CO2 goes up, the patient will not hyperventilate like they would if they were not breathing a volatile anesthetic. All of our inhaled anesthetics, ISO, SIVO, and DES, are bronchodilators. Yes, DES is an upper airway irritant. We would not do a volatile anesthetic induction with desflurane, but it is a bronchodilator of the lower airways. Our volatile anesthetics do attenuate hypoxic pulmonary vasoconstriction. They are vasodilators of the blood vessels in the lung, and HPV is attenuated. Here's a question: which one of the following inhaled anesthetics is appropriately matched with an associated physiologic effect? Does desflurane increase CMRO2? No, it puts the brain to sleep and oxygen use goes down. Does isoflurane decrease cardiac output? Well, cardiac output is maintained. Remember, the inhaled agents decrease SVR, reflex increase heart rate, and maintain cardiac output. Does sevoflurane increase SSEP amplitude? No, it decreases the amplitude and increases the latency. And does desflurane decrease hypoxic pulmonary vasoconstriction? Yes, it does. Which of the following will occur in a patient spontaneously breathing 2 MAC of inhaled isoflurane? Decreased apneic threshold? Yes, the apneic threshold is changed, but is it decreased? No, it's increased. Is the minute ventilation in response to hypoxia increased? No, hypoxic response is blunted. Is the minute ventilation in response to hypercarbia increased? No, the CO2 response is attenuated. Is dead space ventilation increased? And the answer is yes. VD over VT is increased and dead space ventilation is increased. Let's change gears now and talk about some pharmacokinetic principles, keyword based. Volume of distribution refers to a mathematical concept of liters, where if you take drug dose over the attained plasma drug concentration, you obtain this volume of distribution in liters. And the lipid-soluble drugs go to the lipid space of the body, and there's a very high volume of distribution. In fact, we're talking hundreds of liters. Well, obviously we're not hundreds of liters, most of us, in size, so it is a mathematical concept here. The neuromuscular blocking agents are very large ionized molecules that go to the water-soluble space of our body, which is lower. So high VD is associated with our lipid-soluble induction agents, for example, while a low volume of distribution is associated with the neuromuscular blocking agents. Potency versus efficacy. If you look over to the far right and top graphic, you can see the difference between potency or affinity and efficacy or activity. Potency is the relative dose of two drugs to have an effect. For example, fentanyl is more potent than morphine. Efficacy refers to the ability of a drug to produce a certain effect or not. Kinetics, first order versus zero order elimination. At the bottom right of the graphic, you can see zero order elimination. An example of that is alcohol. If you drink alcohol, your body chews away at it the same amount every hour being eliminated. Well, almost all drugs that we administer undergo first order kinetics. So let's focus on first order elimination kinetics. And that is the bottom graphic showing this exponential decrease. Half-lives. Well, the first half-life, if you have 100% of the drug at the beginning, at the end of a half-life, 50% will be left. At the second half-life, you start with 50%, and you're going to have 25% left of the drug at 2 half-lives. If you start at 25% at 2 half-lives and go out to 3 half-lives, you have half of that, and only 12.5% left at 3 half-lives. So that means that 87.5 or somewhere around there percent of a drug is totally gone at 3 half-lives, undergoing first order kinetics. Let's look at drug metabolism now, specifically phase 1 and phase 2 metabolism. The graphic on the far right shows a drug being oxidized in the cytochrome P450 system and being made into a polar ionized metabolite that then can be renally excreted, or the drug can be conjugated, for example, glucuronidated, put a sugar molecule on it, and then excreted either in the kidney or eliminated in the stool, for example. Phase 1 reactions, the classic is oxidation with the cytochrome P450 system, and there are some drugs that affect the cytochrome P450 system. It can be induced with anticonvulsant drugs like Dilantin or Tegretol, carbamazepine. If it's induced, it means those enzymes are revved up, and they're going to chew up drugs that depend upon this system faster. And then there are other drugs, like some of our psychotropic drugs, antidepressants, fluoxetine, other SSRIs, fluoxetine being Prozac, which inhibit the cytochrome P450 system. Therefore, if you inhibit that system, any drug that depends upon it for its oxidation and elimination can have a prolonged effect potentially. Now, there are variations in cytochrome P450 metabolism in different people. Some are poor metabolizers. 7 to 10% of Caucasians fit into this. Some are intermediate, and some are ultra-lipid metabolizers. So you can see how a drug that depends on the cytochrome P450 system can vary in its metabolism between individuals with genetic variation. And remember, we previously talked about opioids and how some of the weaker opioids are metabolized to more potent opioids. Codeine is one example. Dihydrocodone, tramadol, hydrocodone, oxycodone, metabolized to morphine, hydromorphone, and oxymorphone. Notice the codones are metabolized to more potent opioids, the morphones, by the cytochrome P450 system, CYP2D6 system specifically. Fentanyl, remifentanil, sufentanil are not affected much by this system. Phase 2 reactions refer to conjugation reactions, where a drug is combined with a compound such as a glucuronide molecule and then is excreted. Lorazepam undergoes conjugation, lorazepam being Ativan, as opposed to midazolam or Versed, which undergoes a phase 1 reaction, oxidation. So you can see how drugs could interfere easily with midazolam metabolism, while lorazepam metabolism may not be interfered with as much. For example, a drug that is in the psychotropic category or the anticonvulsant category could affect midazolam metabolism. Pharmacogenetics, a couple examples here. The CYPD system, we mentioned that codeine must be metabolized to morphine to be active. And if you have abnormalities or differences in CYPD, for example, the 7 to 10% of Caucasians who don't activate the prodrug codeine to morphine, you're not going to have an analgesic effect. Patients can have atypical cholinesterase. The 1 in 3,000 or so that are homozygous atypical for cholinesterase, you administer succinylcholine, you're going to have a very prolonged hours effect of succinylcholine. Ester local anesthetics can be prolonged, but not remifentanil or esmolol, as previously mentioned in earlier podcast, because those are broken down by different esterases. Remifentanil, nonspecific esterases, esmolol, RBC esterases. Malignant hyperthermia. Succinylcholine and volatile anesthetics can trigger it. G6PD, or glucose 6-phosphate dehydrogenase, or favabines, can cause hemolysis of red blood cells in these patients if they eat them. There are some drugs like antimalarials, sulfonamides, aspirin, methylene blue, and nitrates that can trigger red blood cell hemolysis in patients that are G6PD deficient. So you can see that if you had a case, for example, of methemoglobinemia that you wanted to treat with methylene blue, but if the patient had G6PD and you administered methylene blue to them, they could have hemolysis of red blood cells. Acute intermittent porphyria, AIP, can be caused by the administration of barbiturates. Methylhexatol and thiopental are the classic barbiturates that, if administered to an AIP patient, can ramp up the enzymes, make porphyric agents increased in the blood, and cause acute intermittent porphyria. Next topic is context-sensitive half-time, and by definition, that is the time required for the central compartment drug concentration to fall 50% as a function of the duration of an infusion. Simplistically, what this means is if you infuse a drug for a set period of time and then you shut it off, how long is it going to take for that drug to drop, its drug concentration to fall by 50% as a function of how long you infused it? So if you look at the bottom graphics, you can see etomidate, propofol, ketamine, midazolam, thiopental, and diazepam. And you can see that etomidate, propofol, and ketamine, when infused for hours, the context-sensitive half-time just slowly increases. So these drugs could be used for infusions for extended periods of time with relatively predictable context-sensitive half-times and times to recovery after shutting off the drug, as opposed to thiopental or diazepam, which if you infuse those, you could see that they would not be great drugs for infusion over extended periods of time based upon there are context-sensitive half times. If you look at the far bottom right, this compares opioids, and you can see that remifentanil has a flat context-sensitive half time. Whether 1 hour or 10 hours, it's relatively flat, such that if you shut off remifentanil, it's approximately 4-minute context-sensitive half time. Esterases are breaking it down. Sufentanil has a pretty good context-sensitive half time pattern for infusions, while you can see that fentanyl is not the greatest drug for long-term infusions based upon its context-sensitive half time. Some miscellaneous pharmacology topics we'll finish up on now. Anticholinergic side effects first. You can have CNS toxicity from anticholinergic agents. Atropine and scopolamine have tertiary amines on them, that is NH3. And NH3 is not charged. These molecules can cross blood-brain barrier. Glycopyrrolate, as opposed to atropine and scopolamine, is a quaternary amine, NH4+, makes it charged and doesn't cross the blood-brain barrier. It's those tertiary amines that cross the blood-brain barrier and can cause CNS effects like the dilated pupils and the classic central anticholinergic syndrome, where a patient administered atropine or scopolamine can become very confused and somnolent. And in this patient with central anticholinergic syndrome, if you want to reverse the effects of blocking acetylcholine, you can increase acetylcholine in the brain with central acting anticholinesterase physostigmine. Neostigmine does not cross the blood-brain barrier, so physostigmine or antilirium is specific for reversing central anticholinergic syndrome. These anticholinergics also can cause tachycardia, suppress sweating and result in increased body temperature, relax the lower esophageal sphincter and put a patient at risk for regurgitation, and increase physiologic dead space by their bronchodilatory effects. Anti-emetics next. Some can prolong the QT interval. Droperidol was classic for that and resulted in a black box warning from the FDA, but also our 5-HT3 antagonists or serotonin antagonists on ondansetron, dilasetron also can prolong the QT interval. And there is a risk of torsades de pointes or VTAC being caused in patients with already prolonged QT interval. If the QT corrected is greater than 440 milliseconds or approximately 450 milliseconds in a female, this is considered prolonged QT interval, and administering an agent that prolongs the QT interval even more could put that patient at risk for VTAC. Hyperglycemia can occur with dexamethasone. When we use Decadron as an antiemetic, often combining with ondansetron, especially in diabetic patients, the blood sugar can go up. Parkinson's disease, if a patient has that and already lacks dopamine receptors, if you give them a dopamine blocking agent like droperidol, chlorperazine, compazine that is, metoclopramide or Reglan, you can cause akinesia in that Parkinson's patient, make them so they can't even move. Next topic is metoclopramide and its gastric effects. Remember that metoclopramide has dopamine blocking effects centrally, and we're going to avoid in patients with Parkinson's disease. It does stimulate gastric motility, so if a patient had previous pyloroplasty or intestinal anastomosis, probably not a great idea to be giving something that increases the motility and puts greater stress on that intestinal wall. It does increase resting tone of the lower esophageal sphincter and relaxes the caloric sphincter, so the stomach will empty, and we'll often use Reglan in the case of patients at risk for potential aspiration who have a full stomach, especially the diabetic patient who has autonomic dysfunction and poor emptying. It's not a great antiemetic in and of itself. It has some bad side effects, such as extrapyramidal reactions can occur and may need to be treated with drugs like diphenhydramine or Benadryl. It can cause sedation, and when administered intravenously can cause hypotension, bradycardia, and or tachycardia. H2 receptor blockers are administered to alter gastric pH. Routine use of these is not recommended, but we will administer to patients who are especially at risk for regurgitation and aspiration in an attempt to decrease the pH of the stomach, that is, increase the pH of the stomach above 2.5. In parturients and morbidly obese patients, patients with GE reflux, and patients with anticipated difficult airway, we will often administer H2 receptor blockers and/or PPIs. Remember that when you administer an H2 receptor blocker, the fluid that's already in the stomach is not being changed in its pH. It's the fluid that is made in the stomach after you administer that H2 receptor. And so it doesn't immediately change the pH of the stomach. If you want to do that, you should administer Bicitra orally, a non-particulate antacid, which immediately changes the pH of the stomach when it mixes with it, but also increases the volume of the stomach. It does not facilitate gastric emptying, that is the H2 receptor blockers. Its onset intravenously is about 30 to 60 minutes and lasts about 12 hours. If you give it orally, it takes about an hour or so to have its effect. Compared to PPIs take, that is proton pump inhibitors, have a longer time to onset but last longer as compared to the H2 receptor blockers. Benzodiazepines and their respiratory effects. Benzodiazepines activate the GABA receptor like etomidate and propofol and thiopental and methylhexidol all work through the GABA receptor. Benzodiazepines depress the response to carbon dioxide. You will not hyperventilate as much if your CO2 goes up if benzodiazepines are present. Occasionally, if you bolus midazolam to an older patient, you can see transient apnea. It doesn't usually happen in younger adults, but it is a risk. There's minimal respiratory depression when administered alone and in relatively low doses and in patients without hepatic or renal disease. Remember that midazolam and also diazepam require the CYP450 system to chew it up and metabolize it. And those CYP enzymes are drug inducible. So if a patient is receiving a drug that increases this enzyme activity, they're going to chew up midazolam faster and get less effect. However, if they're administered drugs that inhibit the CYP450 system, for example, some HIV drugs, fluoxetine, Prozac, you may get more of an effect of midazolam after you administer it to a patient, longer duration of action. As opposed to lorazepam, which undergoes glucuronidation as its form of metabolism and is renally excreted. If you combine benzodiazepines with opioids, you're going to get more severe respiratory depression. Flumazenil is the reversal agent for benzodiazepines. It's a competitive antagonist at the benzodiazepine receptor. It lasts about 60 minutes, its half-life. So if you give a patient flumazenil who has previously received lorazepam or diazepam, longer-acting benzodiazepines, when the flumazenil wears off, you may get resedation if it's a long-acting benzodiazepine and require repeat doses of flumazenil. This is similar to naloxone or Narcan and long-acting opioids. Naloxone only has a half-life of approximately 60 minutes, and if you reverse an opioid that's long-acting, you may have to continue an infusion of naloxone or give repetitive doses to prevent re-narcotization of a patient. Flumazenil itself lacks intrinsic agonist effects, so if I gave it to a patient without any benzodiazepine on board, they would not know that they even got it. There would be no effect on the cardiovascular, respiratory, or CNS system, and it doesn't alter MAC. It will reverse hypnosis, muscle relaxation, amnesia, sedation, and anxiolysis in patients that are on benzodiazepines. And at low doses, it will start with anxiolysis. At higher doses, it will reverse sedation and then amnesia and muscle relaxation and finally hypnosis. If a patient is benzodiazepine dependent using benzodiazepine, you can precipitate withdrawal by administering flumazenil to those patients. Dexmedetomidine is the next topic, or Precedex, and its cardiovascular effects. Precedex dexmedetomidine is similar to clonidine in that it is a alpha-2 agonist, but it's more selective for the alpha-2 receptor than is clonidine. By agonism at the alpha-2 receptor, presynaptically inhibits norepinephrine release, both centrally and peripherally. If you have less norepinephrine in your central nervous system, it tends to provide sedation. It also decreases MAC. It has an analgesia, a morphine-sparing effect. It has very little effect on the respiratory system and does decrease sympathetic activity. Because it's decreasing norepinephrine, it can decrease systemic vascular resistance and heart rate, and be cautious in patients with heart block or severe LV dysfunction using Precedex. Interestingly, if you bolus Precedex, you can get a transient and paradoxical hypertension rather than hypotension that occurs. Hypertension in bradycardia may be seen during infusion of a loading dose, and this is probably due to initial stimulation of alpha-2 receptors in vascular smooth muscle with vasoconstriction. You can avoid that by just giving lower doses over longer periods of time. Interestingly, we don't see the rebound effects after discontinuing dexmedetomidine infusions like classically with clonidine. If you stop clonidine before a surgery, for example, in the preoperative period, take off a transdermal clonidine patch, for example, or stop clonidine before surgery, you can get rebound hypertension. Dantrolene pharmacology is the next topic. We know that dantrolene is the treatment for malignant hyperthermia and also for neuroleptic malignant syndrome. It blocks calcium release from sarcoplasmic reticulum. And if you look at the far right graphic, you can see SR in yellow being the sarcoplasmic reticulum that releases calcium and also reuptakes calcium. If you block the release of calcium but don't block the reuptake, you can see how calcium in the inside of the cell can be reduced, and that's the mechanism of dantrolene during malignant hyperthermia. Prophylaxis with dantrolene is not used in patients that are MH susceptible. We don't prophylax patients anymore, but have it available and use non-triggering anesthetics. We do not use calcium channel blockers with dantrolene. For example, if a patient develops an MH episode, is being administered dantrolene, and developed SVT, don't think about using diltiazem with dantrolene. The combination of those two can produce hyperkalemia and severe myocardial depression. The side effects of dantrolene, if I give it to a patient, it can weaken the muscles some, they can get nauseated, a little sedation, and if administered over days, they can get increases in liver function tests. You may also see patients who have neuroleptic malignant syndrome due to antipsychotic agents. If you give dantrolene to, you can get a decrease in temperature in those patients. Neuroleptic malignant syndrome goes by slow onset MH. It looks like MH, but it's slow onset and is secondary to antipsychotic medications, and dantrolene can be used to treat it. The common pharmacology, this is a question, between naloxone and flumazenil include which one of the following? Competitive antagonism at receptors, long half-life, cardiac dysrhythmias and pulmonary hypertension, a complication of bolus administration, seizures, a complication of bolus administration. So common between these two is that they're both antagonists at receptors, naloxone at mu receptor, flumazenil at the benzodiazepine receptor. They both have short half-lives, about 60 minutes. Naloxone can cause cardiac dysrhythmias and pulmonary hypertension if you rapidly reverse a patient on opioids, and seizures can be a complication of bolus administration, and that's can be associated with patients who are chronically taking benzodiazepines. The next topic is anaphylaxis. Anaphylaxis is type 1 mediated IgE that goes to mast cells and basophils and causes them to degranulate. These mediators can cause some very bad things. Histamine increases capillary permeability and vasodilates and causes bronchoconstriction. Leukotrienes also increase capillary permeability and bronchoconstrict and can cause negative inotropy, and prostaglandins can bronchoconstrict. So you can see these mediators cause bronchoconstriction. We can lose fluid from the intravascular space into the interstitial space because of the capillary permeability, and can have negative inotropy. So these patients can be hypotensive, hypovolemic, bronchoconstricted, wheezing. And when you see that patient with a rash, hypotensive, hypovolemic, laryngeal edema, bronchospasm, arterial hypoxemia, you think this is anaphylaxis. And plasma histamine will go up, but its levels return to baseline very rapidly. In fact, in about 30 to 60 minutes. Plasma tryptase from mast cells increases within hours and remains increased for a longer time than histamine, and can be a laboratory way to help diagnose anaphylaxis after the fact, because you really, if you believe it's anaphylaxis, you should administer epinephrine early, usually lower doses, 8 to 10 mics IV initially, and increase as needed. Perioperative antibiotics and neuromuscular blocking agents, specifically rocuronium and succinylcholine, are the things in the perioperative period that often result in anaphylaxis, or most commonly result in anaphylaxis. Interestingly, if a patient is penicillin allergic, we have worried in the past about cephalosporin cross-reactivity. And newest evidence suggests that if a patient has a rash to penicillins in the past, that you can safely administer cephalosporins to these patients, and we do. But if a patient has a penicillin allergy with anaphylaxis, then we avoid cephalosporins. Why do we give epinephrine early to a patient with anaphylaxis? And why is it so critical? Because epinephrine increases intracellular cyclic AMP and restores membrane permeability and stops these vasoactive mediator release. Not only does it stop vasoactive mediator release, but it also has a beta agonist effect and relaxes bronchial smooth muscle and causes bronchodilation. Ketoralac and renal function. Ketoralac, Toradol. These drugs like Ketoralac and ibuprofen block prostaglandin-mediated effects of renal blood flow, and it actually reduces renal blood flow and can cause acute renal insufficiency or ischemic acute renal failure. Those that are predisposed to this are the elderly, the critically ill, those with congenital heart or CHF, congestive heart failure, that is, renal or hepatic dysfunction. And we're most concerned causing renal dysfunction in patients that have advanced age, already coexisting renal dysfunction or renal hypoperfusion, undergoing major surgery, who have sepsis or other risk factors for acute renal failure. So we're careful about who we administer Toradol to, Ketoralac to, and the dose that we administer. Other renal effects of Ketoralac include proteinuria, interstitial nephritis, and papillary necrosis. We tend to not exceed a couple days of IV or IM dosing of this drug. What about herbal agents and supplements in the perioperative period? If you have the opportunity to discontinue them a week to 2 weeks before surgery, that's probably a good idea, with the exception of valerian, which you don't want to acutely just stop because it's a CNS depressant. Mandatory discontinuation of herbals, though, is not necessary, and you do not need to cancel surgery if someone comes preoperatively who's taking them. And even if they're taking the classic G herbals, the things like garlic, ginseng, ginkgo, and ginger, which interfere with platelet function, even those are not a contraindication if they're taking them even the day of surgery to neuraxial anesthesia, according to American Society of Regional Anesthesia guidelines. Let's talk about diuretics now, just briefly. Lasix or furosemide has an onset very quickly in about 5 minutes. Its maximal effect is in about 20 to 60 minutes and persists for several hours. It inhibits sodium and chloride reabsorption in the thick ascending limb and also causes sodium, calcium, and magnesium excretion and loss of free water in the urine. When you administer furosemide intravenously, it not only starts to initiate a diuresis, but one of the very first things that it does is cause venodilation. So in a patient with congestive heart failure administered IV furosemide, they receive a beneficial effect by that venodilation and decreasing end diastolic volume and reducing potentially symptoms of CHF even before the diuresis. Use of furosemide over periods of time can cause a contraction alkalosis, a metabolic alkalosis, One of the side effects is hearing loss and hyperuricemia. Let's compare furosemide to mannitol now. Mannitol is not a loop diuretic, but an osmotic diuretic that can lead to volume depletion and electrolyte imbalance, losing electrolytes in the urine. It's not very effective in preventing acute renal failure, but is used in renal transplantation, usually just before reperfusion of the transplanted kidney. When you administer mannitol to a patient, it initially draws fluid into the intravascular space. This drawing of fluid into the intravascular space can precipitate congestive heart failure in patients with low ejection fractions and poor LV and RV function. So be very careful about administering mannitol to a patient in heart failure. Lasix would be a better choice. It can decrease intracranial pressure in about 30 minutes and has its maximal effect in about 1 to 2 hours. Thiazide diuretics inhibit sodium transport at the distal convoluted tubule. Notice at the far right you have the loop diuretics in orange, the thiazide diuretics in greenish color, and those thiazide diuretics can cause dehydration, hypokalemia, metabolic alkalosis, and some unique things, hypercalcemia and hyperuricemia. Diamox, or acetazolamide, is a diuretic that inhibits carbonic anhydrase, and it's shown in blue on the graphic on the far right. That carbonic anhydrase inhibitor inhibits absorption of bicarbonate such that you lose bicarbonate in the urine. If you lose bicarbonate in the urine or alkalinize the urine, the body becomes acidotic. And metabolic acidosis can occur. So if you draw blood gas in a patient taking Diamox, for example, a patient who has glaucoma who's taking Diamox, or preparing for a high altitude climb who's taking Diamox, you can see a metabolic acidosis. And in red is the osmotic diuretics like mannitol. Lastly, spironolactone or aldactone is an aldosterone antagonist. Acts at the distal tubule. It's shown in the violet or purple color on the far right, and it inhibits sodium and potassium excretion. It's a weak diuretic and can cause hyperkalemia. Let's finish up now, last couple slides, with anticoagulant action. Warfarin or Coumadin inhibits the synthesis of vitamin K dependent factors 2, 7, 9, and 10, and we often forget about the anticoagulant proteins C and S that warfarin also inhibits. We monitor warfarin effects classically with the PT-INR. So at the far right you can see warfarin inhibiting 2, 7, 9, and 10. Low molecular weight heparin, like unfractionated heparin, acts via antithrombin 3, so it's an indirect inhibitor. It binds antithrombin 3, accelerating antithrombin inhibition of clotting factor 10A. An important point is that antithrombin plus the low molecular weight heparin does not inhibit thrombin itself, thrombin being 2, like unfractionated heparin. Very important point. So it's inhibiting factor 10A, but not thrombin, factor 2, like unfractionated heparin does. So we can't monitor it with PTT like we do heparin's effect. If you wanted to monitor low molecular weight heparin's effect, you'd need to monitor anti-factor 10A activity. Fondaparinux, another drug that can be used like low molecular weight heparin in an attempt in the perioperative period to reduce the incidence of thromboembolic events, inhibits 10A also via antithrombin. It's not a direct thrombin inhibitor, and it has less chance of heparin-induced thrombocytopenia than does heparin. It also doesn't increase the PTT. Heparin, when administered unfractionated, such as we do administer prior to cardiopulmonary bypass, binds to antithrombin 3. And when it antithrombin 3 is activated, it inactivates thrombin, 10A, and other proteases. So not just 10A, but also thrombin, and we monitor heparin's effect with a PTT. The last anticoagulants are clopidogrel, bivalirudin, and dabigatran. Clopidogrel, or Plavix, is a prodrug that requires activation by that CYP system, specifically CYP2C19, and then the drug acts on ADP receptors, inhibiting platelet aggregation. The drugs used to treat clotting disorders are shown on the far right. In red is the anticoagulants, and in blue is the antiplatelet drugs, and in green is the thrombolytics. So if we look at the antiplatelet drugs in blue, you can see aspirin is a COX inhibitor, while there's multiple drugs that inhibit the G2B3A receptor, and then clopidogrel, the prodrug that has to be converted to the active form that inhibits ADP receptors. Now, bivalirudin is a drug that is a direct thrombin inhibitor, so it's an anticoagulant. And if you look at the anticoagulants on the top right in red, there's many of them. There's some DTIs, direct thrombin inhibitors, like the new one, dabigatran, argatroban, lepirudin, and then the indirect thrombin inhibitors that act through antithrombin 3, heparin, fondaparinux, and low molecular weight heparin. Then anticoagulants that act via reduction of vitamin K dependent factors like warfarin. And then there's direct 10A inhibitors like those shown here, some newer anticoagulants. Bivalirudin is a DTI, or direct thrombin inhibitor, that depends on the kidney for its clearance and can be used to anticoagulate patients for cardiopulmonary bypass who have a history of heparin-induced thrombocytopenia, where you want to avoid heparin. Dabigatran, or Pradaxa, many patients with atrial fibrillation are on this drug now. It's an oral direct thrombin inhibitor with a half-life of about 12 to 14 hours. It prolongs the PT, PTT, INR, but doesn't do so linearly, so we do not monitor these patients' coagulation status, but just administer the drug. This gets patients potentially in trouble who are taking this drug, get into trauma, and are bleeding. And fortunately, there's direct reversal agents now available to reverse dabigatran. This ends our discussion, three-part series on keyword review of pharmacology. Hopefully you learned something from these podcasts and you enjoyed them. I wish you the very best. This is a picture from Italy, a biking trip I took this summer. Have a great day.